This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
Prof, we have a couple of questions live. When do you recommend laparoscopy in unexplained infertility? What findings often change treatment direction? And the other question is it possible to get pregnant if a woman has autoimmune diseases?
Yeah. Okay. Start with laparoscopy and me. When someone has what's been defined as unexplained infertility, in other words, for that definition, we would say that the husband or the partner's sperm has been tested and it's fine. She has a regular cycle with ovulation, proven with progesterone testing, and she's had tests of that the tubes are patent, and they are patent. Then we end up with a diagnosis of unexplained infertility. It's not really complete at that point because we really don't know what's going on inside the pelvis. Modern ultrasound is very good, provided it's done by an appropriate ultrasound service that is focused on women's pelvises. So ultrasound for women is where you would start with that. Just the local radiology department may not have a sonographer with the same sort of training and interpretation. So that would be my one step before a laparoscopy, because often that will should potentially show the one thing we're going to really be looking for with a laparoscopy, and that's endometriosis. In about 15% of patients with endometriosis, when we do laparoscopy, we find it even though the woman has no symptoms of endometriosis. When I sit down with a patient with unexplained infertility, I am very careful with the history I take to make sure there are no signs that it might be endometriosis. Signs like pain starting before the period and even after the period is finished, the pain going on after that. Pain with intercourse is another symptom. So those sorts of symptoms are vital to collate, and certainly that would move me very quickly to suggest doing a laparoscopy before we do anything else. If a good ultrasound has shown the tubes are open and there is no signs of endometriosis, then I would encourage patients initially, in a month or two after the HyCoSy or whatever the tubal patency test is, to keep on trying, because there is an increased risk in getting pregnant in the first couple of months after flushing through the tubes in women who otherwise were thought to be unexplained infertility. If that fails, then obviously we're thinking about moving on to IUI or IVF. Whether you should have a laparoscopy before that is not necessarily the case if a good ultrasound has been performed. But if any symptoms or signs of endometriosis, then I would be definitely suggesting a laparoscopy. The next time I routinely do a laparoscopy is after you've been through an IVF cycle twice, you've had 2 embryo transfers and they haven't got you pregnant. Then I think it is important to have a laparoscopy performed, again, to make sure there isn't silent endometriosis that we've missed. So it's not essential that every woman has a laparoscopy with unexplained infertility, but it may reach a point that it is a reassurance that there isn't anything else nasty going on that's stopping you getting pregnant that could be treated.
Prof, we have 2 more questions live. Okay, Alana asks, question, frozen cycle, HRT and double hormones and failed IVF, what other cycles are feasible for older ladies?
Start there. So the options with frozen embryo transfers are, as she says, hormone replacement therapy. That's not vital if the woman is still ovulating on her own. If she's got a regular cycle and still making an egg each month, certainly I tend to start off with a natural cycle, or maybe a cycle stimulated with a low dose of hormones to make sure ovulation is good, together with support in the second half of the cycle with progesterone. The other probably addition to that, if we're talking about older women, is the importance of getting those embryos genetically tested before they start being put back. If you are 40, for instance, and you've got day 5 embryos, if you're lucky enough to get that far, at least 3 of those 5 will be genetically abnormal on average. So putting back those, if you had the bad luck to put those back first, then you will have failed IVF. But in fact, you may have 1 or 2 embryos that are still good. When you get to 43, it's even worse. That if you've got 5 embryos, and it's very rare for a 43-year-old to get day 5 embryos, but 4 of the 5 will be genetically abnormal. So getting the genetic testing on those embryos is very helpful in moving towards getting a pregnancy sooner rather than later. Obviously, the laboratory is not going to throw out any embryo, so eventually if you've got 5 embryos, you'll eventually get to the one that's good. It's just that genetic testing makes it much sooner, and you're not going through the pain of repeated failure. So my suggestions are natural cycle if you're still having a period, making sure that your embryos have had the genetic testing if you're over 40.
Prof,
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.